Joining us live now on the KK Factor is a man whose work changes lives every single day. Dr. James Dimou, a respected neurosurgeon, is here to talk with us about the brain, neurological health, recovery, resilience, and the reality patients and families face behind closed doors. Tonight's conversation is an important one, from life-changing diagnosis to hope, healing, and medical breakthroughs. We're diving into a world many people don't fully understand until it touches their own life. So I'd like to please welcome live to the KK Factor neurosurgeon, Dr. James Dimou. I've got to put his mic up. There we go. Hello, James.
Good evening, and good evening to all of your listeners.
Good evening, James. First of all, how was your day? Let's run through a day for a neurosurgeon consists of.
Well, today actually I was I did a ward round and then was doing a lot of paperwork and bureaucratic type stuff. But an emergency case, or not an emergency, but an urgent case that needed a brain tumor patient who came in over the weekend. We had some time on the emergency list, and we were looking to do that starting in the early afternoon, but the patient was basically too unwell to have their operation. Her heart started playing up, blood pressure was going up and down, heart rate was going up and down, so she wasn't stable enough to have the surgery, unfortunately, which meant that the afternoon for me was relatively relaxed. I went for a walk around the botanical gardens and returned home for dinner.
I actually like that you shared that story, and I thank you so much for that. It's important for our listeners to hear real life stories and stories that can be complicated as such, but it was also great to hear what you do to help yourself and your mental well-being, especially after days like that and situations like that. I guess, are they like the main challenges, and what can you do for patients like that, James?
Well, the patient that you're talking about the patient today that didn't get her operation?
That's right.
Yeah, so we just have basically the plan. She needs her operation, but she's basically not well enough to withstand the general anesthetic, and she's an older patient. So we will basically get new medical review, do some more investigations, get her as well as possible so that we can try again maybe Thursday, maybe even later in the week, or maybe even early next week. Depends on when we feel like she's ready. But unfortunately, she's not able to go home the way she is. The tumor is too big, and it's causing her a lot of problem with her walking, with her balance. So it's an older patient who usually lives at home alone, fairly independently, but she's not able to do that at the moment. So there may be some time yet before we're in a position to be able to do her operation.
I thank you. It's great to know that the medicos behind the scenes do such work, particularly in these situations. We'll dwell into the understanding of the causes, or some of the causes. What are the most common hidden causes of chronic back pain people often overlook?
Yes, I think it's important to sort of understand that what most people define as back pain, we in the medical fraternity would broadly call it degenerative. So essentially, it's related to the type of arthritis that patients get in their knees, in their hips, shoulders, etc. But the really important thing, and it's very common. So degenerative back pain is something that will affect almost 80% of adult Australians. It's a very common condition. The really important thing with degenerative back pain, though, is excluding occult, sinister pathology, which, if not picked up early, can lead to obviously very bad outcomes for a range of reasons. So really the main things that we as neurosurgeons ask primary care providers like GPs or physios to watch out for is, do the patients have symptoms and signs which are suggestive of maybe an underlying cancer? Have they been losing weight? Have they lost their appetite of late? Is a sort of different sort of constant gnawing ache low down in the back? Infection. So, does the patient have unexplained fevers, unexplained sweating? And that's particularly important in today's society because because Australia is accepting more and more migrants from countries where tuberculosis, for example, is endemic. And as clinicians, we are definitely seeing that more and more. Not to say that it's super common, but we're certainly seeing it more frequently than we were even 10 years ago.
Wow.
And there are other inflammatory, what we would call inflammatory or autoimmune type arthropathies, which are not so easily diagnosed because of the sort of unusual nature in which patients present with low back pain, but nonetheless would be another category of patient that needs to be diagnosed early, because if they can be treated earlier with some of the medications that are now on offer, because monoclonal antibody therapy in a lot of these autoimmune conditions has really revolutionized treatment, then the sooner that that's diagnosed and acted upon, the better for patients who are involved. So they're the three main groups of patients that we want to make sure when someone presents with back pain, we want to make 100% sure they do not have one of those three. There are some others as well. Sometimes even an innocuous trauma might be something that needs to be detected early if it's an unstable fracture. That's unusual, but does happen very occasionally. That's another smaller category.
Now,
but those things need to be excluded before patients can, have their management for what we would term as clinicians as degenerative back pain.
Okay, so degenerative back pain, is it true to say that it mostly happens as we get older? I know there are rare occasions with the younger people. So is that why the event that we'll talk about throughout this conversation, the event that's coming up at the new Footscray Hospital, how amazing is that? You've collaborated with Broina, and Broina's known to have, it's a care facility, aged care facility, but if it's for younger people, I think the oldest is 67 or just under 70. So the event, will that be focusing on degenerative back pain?
Mostly, yes. So the event is the event is designed to clear up any misconceptions about how low back pain is managed, how it's investigated, what are the red flags, what we do as clinicians across many specialties to manage low back pain. And I think also in the degenerative setting to really emphasise that the mainstay of treatment really is well away from the operating room. So yes, there is a role for surgery in managing low back pain. And there'll also be some discussions about low back pain, but also other spinal presentations. So patterns
like
of pain.
muscular, nerve-related?
Yeah. So patterns of pain, patterns of weakness, sensory disturbance, etc., that perhaps warrant a different approach. And we'll cover all of that in the 2.5 hours that we have on offer for the community members who attend on May 31.
May 31, and it's a free event as well. Dr. Dimou, at what point should someone stop pushing through the pain and seek specialist help? Now, the reason why I'm asking this question is everyone's got a different pain threshold. So as an example, I'm very open to my listeners. So in 95, I was in a very bad car accident and I remember the pain, and I was heavily medicated to cope. But there was also the factors of my mental health. And the more upset I was, the more my pain was, was worse, far worse than normal. And in time, the degenerative back pain kicked in, which I was explained that you've had your car accident at a young age, but due to that, your discs are going to degenerate, which is going to cause other issues. So prolapsed disc and pinching of the nerves, et cetera, et cetera. And I remember really pushing hard to the point where I couldn't cope. But I was trying to wonder, was it the pain I wasn't coping with, or was my mental health, or was it making it far worse before I went to seek further help?
Well, mental health plays a big role, but I would certainly say if patients do have low back pain, the first port of call really should be your local doctor. And your local doctor will know what to do in terms of ruling out red flag symptoms and ruling out sinister conditions. So we'll know there's some basic investigations, a few blood tests, but mainly related to CT and X-ray.
An MRI?
So the MRI is a little bit different because it depends also. So the way the funding arrangements are with Medicare is that MRI, at least in the lower back, a little bit different in the neck, and that covers the same sort of symptom. But in the lower back, it's hard for a GP to organise an MRI scan. Well, they can organise an MRI scan, but it's not rebatable under Medicare.
That's right. You got to see the specialist in order to have the rebate.
Yeah. Which means that the patient would have to pay if they really wanted an MRI, and that's obviously the gold standard investigation. Then the patient would have to pay for that, unless they got referred to a specialist like myself, and we can order the MRI scan. In that case, then that scan can become rebatable under Medicare, and patients don't have to pay out of pocket. But actually, a CT as a screening test can give a lot of information. And also, the other thing is that the GP needs to, yes, rule out red flag conditions, rule out red flag symptoms and signs, but also there are many other conditions, pain syndromes, which may present as spinal but may not be. So one that I've picked up a lot, actually, probably more so than what I would have expected when I was going through my training, is, many patients who come in with low back pain or with, with symptoms that are being presented to me in the referral as a spinal presentation as such. Some of these patients have got, for example, really bad hip osteoarthritis.
Yeah.
I've sent at least 3 or 4 patients who initially, when I did, they was told got some back pain, et cetera, but when I examined them, when I took a more detailed history, did a more detailed examination, did some extra investigations, it was clear their problems were actually in the hip,
Wow.
not in the back. And that's happened far more frequently than I would have ever imagined. So it's really important for patients to see their GP first.
To rule out everything first. Okay.
Yeah, so that's really important because the GP will be the GP's job is to make sure that nothing really bad is happening. Degenerative low back pain otherwise is it's something that can definitely be managed. Part of that management is also related to expectations, because some people think the pain will go away forever. In most cases, probably won't. But the issue is, or the challenge for patients is to develop strategies, and there are a range of different things that patients can try, and they'll find out about all of this at the event. There are a range of things that patients can try to improve their symptoms and to make them much more manageable, and fundamentally it's about returning to the baseline work and leisure activities that the patient is used to.
I think that's fantastic that they're going to cover that at the event, because as someone who has got back injuries, and I've got no disc in my L3, degenerative, it's all gone down the bottom, L4, 5, and this and that, and I've got severe back arthritis, which is what you mentioned. And, I wish someone back then, over 20 years ago said to me, this accident that you've had and these little accidents you've had along the way will result in arthritis as you're getting older. And it's true, because at that point, the pain was controlling me, but then I learned how to control the pain. It's not an easy step, but it was me talking to medicos, going and seeing a psychologist. How do I deal with this? And having that understanding. And it's good that at this event, you're going to dwell into that so people learn.
Yeah, I think you made a really good point about the psychologist, because, and that's not going to be an approach for everybody, right?
No, it won't.
Clearly, hearing you tell your story, that's obviously in your in your
I wanted to.
your way of managing it,
Yes.
going to a psychologist really helped you. Now that's not going to be the same for the next, dozen patients
No, it doesn't work for everybody. No, that's right.
But I can use my own father as an example. He's had low back pain for decades, but he has his routines. He sees a physio 3 or 4 times a year. He worked out that actually staying mobile was very good for him.
Yes.
So he walks frequently. So that's what he does. And he knows when he has an off day. And this is the other thing as well. There's low back pain, and then patients can have flare up. And if you have a flare up, then sometimes all you can do is get some Panadol, get some anti-inflammatories. If you happen to have
don't get a shotty of port on top of that. It did work, but not something.
And just take the tablets and lie in bed and just rest up. It'll get better, but
yes, it
can be very, very painful. So it's about It's about having a strategy, and the patients who do well, and people who meet my father, just as an example, would have no idea that he on more or less a daily basis is managing low back pain.
Isn't that amazing? My mother's the same. She's had 2 back surgeries. I think they're called discs, when they put discs. I can't remember the terminology. Yep. 2. And yet she's still out there fishing, getting in her boat, doing, different things. But yes, she needs to be very careful and not pick up, very heavy things, but she's managing. And I think having that mental strength is a key, because at the same time when my mother had the surgery, a male friend of mine also had the surgery, who was half the age of my mother, and he couldn't cope. They both did rehab. They both did everything. They both had the same surgery, but he couldn't cope. So I really believe you need support people, positive people. For me, back at that time, I saw a psychologist because I needed someone more positive that understood to help me. Sure. Nowadays, there's more awareness. People are more open, talk about it. And I think that's another key to helping.
Well, the thing that I tell all the patients that come and see me in my rooms who have degenerative low back pain for which there's no obvious surgical cause, so certainly nothing that can be remedied with surgery, I tell all of them, I say, you need to put together a plan. And the plan, I can't be prescriptive, because the plan that might work for you, I can 100% guarantee you is not going to work for the next one who comes in.
That's right.
And so it actually makes low back pain, in one sense, a very sort of individual condition.
Dr. Dimou, what exercise or movements do you wish more people did consistently?
Yeah, that's an interesting question. It's I'd say in some respects, controversial is maybe a strong word, but certainly a question that would raise some conjecture.
Because you said your father would get up and walk.
Think prolonged sitting is not great.
Yes.
I'd say if there's one thing that people should do is try and sit less. Get a standing desk, or if you have to sit, get up and get out of the chair for every 45 minutes or an hour. I think that it certainly doesn't help one's spinal health.
Okay.
But the human body. I mean, we can see, just as an example. I mean, if you look at the Olympic Games, the World Cups just around the corner, you can see and these admittedly are younger people. They're much better trained and in better health, more fit. But you can see the human body is designed to perform some pretty incredible feats of sort of physical strength, etc. So I think that also needs to be borne in mind, that it can be very easy to develop a defeatist or a nihilistic mindset. But in actual fact, your body is very capable, if it's given time, and if you listen to it, and if you start to put in place the right sorts of activities, strategies, remedies that are right for you. And as I said, that for every patient, it's going to be different.
Exactly. I just want to quickly touch on surgery. What's the biggest misconception patients have about back surgeries?
The biggest misconception that patients have about surgery is that back pain is cured by surgery. So, and what I mean by that is if I talk simply about patients who come in with midline, or axial is another word that we use in the medical fraternity, axial neck or back pain is cured by surgery. In actual fact, very few patients select themselves out as being surgical candidates for that. So I've been back in Australia working as a neurosurgeon for 7 years, and I've probably done literally one back pain or neck pain operation per year during that time.
Wow.
Where we do a lot of spinal surgery is where the degenerative spinal processes start to cause nerve compression, spinal cord compression. That's where surgery plays its role, and that's by far and away the most common indication for surgery. The most common indication for surgery are those patients we're talking about degenerative spine again, are those patients, for example, like I think you alluded to before, they have a disc prolapse. The disc prolapse is compressing the nerve. It's causing pain down the leg or altered sensation, pins and needles. It doesn't get better after a couple of months. And so those patients get really good relief from surgery, and the surgery comes with risks, and there's also risk associated with what might happen after the surgery, but by and large,
which is common in most surgeries.
Yeah. But those patients who have nerve-related symptoms from nerve compression, they do very well. And that the vast majority of patients who get spinal surgery are in that boat, and there are a lot of different types of operations that we as surgeons can do to get a good result. Sometimes patients need a fusion. Sometimes they need a much more straightforward operation. Just depends on a whole range of different factors. But for low back pain itself, without a sinister cause, so just degenerative low back pain, the role for surgery is actually very minimal. But it's there, but it's actually limited.
You mentioned earlier that the event that will be happening at the new Footscray Hospital, the free event on May the 31st, you're going to also be talking about technologies. So what new technologies or treatments in neurosurgery are exciting you mostly right now? And do AI or robotics have a growing role in spinal surgery?
AI, not quite yet. Robotics, not so. We're not quite at the robotic age yet, but we're very close. So neuronavigation systems are more or less par for the course now in spinal surgery, at least in Western countries, so like Australia. Robotics is really just one step beyond that. There are some robotic systems out there, but I wouldn't say they're widespread.
Not just yet.
I think the big advance, which has been a little bit slow coming to Australia. I think the big advance is endoscopic spine surgery. So basically, doing spine surgery on a big screen with little cameras being introduced to the area that needs to be operated on. So it means smaller cuts, less blood loss, potentially better outcomes for patients, less healing time, and so on. So I think that's certainly more widespread overseas. That originated in Germany, nearly 20 years ago. But as I said, has certainly become more prominent in Australia maybe the last 2 or 3 years, with one or two of the major spine surgeons in Australia, including a surgeon in New South Wales by the name of Rafe Mobbs, who does a lot of spine surgery. He's really taken it on board. So I'd say that's actually a really big one. So it's maybe one that members of the public don't really know much about. But also there are some centres that still don't offer it. It's still, in Australia, like I said, very new.
So what new technology, without telling us too much, because we want to look forward to May the 31st, what new technology will you be touching on?
Well, I'll be basically touching on all the existing technologies that we use to do our spinal surgeries, but also looking forward to what is potentially available overseas So one of the difficult things though about these new technologies is that they all sound great, but also you need basically the specialty needs to develop the evidence base for them. So it's all well and good to have a piece of fancy equipment, but if it's not actually necessarily delivering a better outcome, then do you really need it fundamentally? We'll be touching on that as well.
Tell me, what inspired you to specialise in neurosurgery and spinal health?
Well, to answer the second part first, I mean, spinal surgery in neurosurgery is, really, at least in this country, is a really big component of a neurosurgical practice. And most of the work that comes, at least in the, well, I think most of the work that comes into a neurosurgery department in Australia, at least half of it will be spine, and in some units it's much more. In private, there are some neurosurgeons who only do spinal surgery, or maybe doing 90 or 95% spinal cases. So which gives every indication of just how common degenerative spinal conditions are in our community. That it almost overwhelms, all the other cranial neurosurgery that's that I guess neurosurgery is famous for, if you like. So aneurysm surgery, brain tumor surgery, skull-based surgery, deep brain stimulation for Parkinson's, for example. That's actually a very small component of the work that is done in a neurosurgery department. So I think in Australia, if you want to become a neurosurgeon, it just goes without saying that at least part of your work is going to be managing spine patients, and some neurosurgeons invest in that more than others. Why I chose neurosurgery, it basically came down to a final choice. I'd chosen surgery over medicine pretty early on during my medical training, and I'd whittled down each specialty based on a range of different things, various experiences, interacting with people, getting advice, etc. And I was down to my last two, was between neurosurgery and cardiothoracics, and they just happened to be the two resident terms that I started with in my second year as a doctor. And I started with cardiothoracics, and that was pretty good. And I thought, I'll be happy enough with this. And then I did neurosurgery, and it was a little bit better, so I stayed with neurosurgery. That's
amazing. It's an amazing story. What's the most rewarding part of helping patients with debilitating pain?
Yeah, there's one patient who I recently operated on who I have great recall for her, simply because of how much of a difference the operation I eventually did for her made to her overall self-esteem and well-being. So this is a woman who had pretty significant spinal degeneration, also had a bit of a scoliosis or a curve in the spine. So she was a very difficult case to manage in terms of knowing exactly what to do. She also was carrying a little bit of weight, which often happens because patients can't mobilize as well as they would like. In the end, we went for an approach where basically did a fusion, but also it involved on her part, basically taking part in what we would call sort of almost like a pre-rehabilitation, where she was asked to lose some weight. She went on to one of the newer weight loss drugs. She did a little bit of physio, and so her weight dropped from about 120 kilos to just over 85, 86 kilos.
Wow, what an accomplishment. Well done to her.
So she lost all that weight. We then did the operation, and when I saw her at a post-op, in fact, no, a 6-month review. So she'd got through the operation. She came back for a 6-month review. The images had shown that she'd already fused. So that was it. There was nothing to do, and her symptoms were significantly better. And I wish I'd done it before and after. It was basically like a Jenny Craig ad. Like, she was so much happier. She gave me a big hug at the end of that consultation. I haven't heard from her since. That wasn't too long ago.
That's a good thing. That's a good thing.
No, it is a good thing. If you don't, usually no news is good news in spine surgery, but that one case definitely rings very clear in my mind.
Wow. Okay, let's touch on this event. Why is the Hellenic Medical Society holding the event out west? Is it because of the new hospital?
Yeah, so I think it really does. I think it's an excellent opportunity to reach out to people out in the western suburbs to be involved in a sort of a medical education event. I think in a sort of in a new environment. As part of my duties as a neurosurgeon at the Royal Melbourne Hospital, I also operate at Footscray, so I spend 5 or 6 sessions there a month. I'm quite familiar with not only with the hospital but also with the western suburbs in general. Although this is an HMSA event, we are working very hard to include all members of the community. So we've reached out to a couple of community groups in Werribee, a Vietnamese community group, also one of the Cypriot groups out west. So we are actively reaching out, and this event is open
That's a great incentive to hold it there then, and to have people come along from all areas of Melbourne.
Yeah, well, I think also looking at the HMSA, and I can't speak for, even if you look at the Greek community, the Greek Centre is great, and, a lot of events, but most of the events are held either in the city or, eastern suburbs, maybe out locally. And
hospital. That's a great way to showcase the new Footscray Hospital as well.
Yeah, so I think it's an opportunity for anyone out west to be involved in a community event which is going to be held at a very high level. We've got interventional radiologist, a neurosurgeon, a GP. So Roula Krikellis is in fact the vice president of the HMSA, and is actually is really interesting. At an earlier HMSA event in the year, I just floated to her whether or not she wanted to be involved in a panel for the back pain event. She said, "Oh, you don't want to talk to me?" I said, "Why don't I want to talk to you?" She goes, "Oh, because I treat low back pain with acupuncture." I said, "You're exactly who I want to present at the session, because
That's fantastic. So you're showing different ways that you can deal with back pain and what you can do. There's more natural therapies, there's surgery, there's a lot of things.
Yeah, and in actual fact, so her practice, she actually does see a lot of, as it turns out, she actually manages a lot of low back patients. Now, those patients are not getting surgery, and they're, I assume, happy with the way that they're being managed. Acupuncture is, one of those modalities which is, uncertain to know of the benefit of acupuncture, but certainly does seem to help, patients on an anecdotal level, and there's certainly no significant side effect. So there's, as I said, every patient will have their own journey.
That's right. And what works for one won't work for the other. And talking about acupuncture, I actually did, when I had a prolapse disc, I remember I went and saw a chiropractor. Other people prefer to see a physiotherapist. I just happened to fall in the hands of a really good chiropractor. And he said, I can't touch your back. So we used acupuncture with electrolysis.
Yep.
And I will say it did, within 2 weeks, from not being able to sit down or go to the toilet, but from not being able to do that, in 2 weeks I was Greek dancing. And it was like,
amazing.
That worked for me. For me, it worked.
Yeah,
okay.
That's right.
So this is, so you've got a huge range of professionals involved in the panel discussion, which will give us their own view. That's fantastic. What are you hoping people will learn or get out of the event?
Yeah, well, I think most of all to sort of dispel any misconceptions about how back pain is managed, and with that, educate people so that they understand that there's what low back pain is, what is it that we as clinicians are actually really worried about. Well, we actually are not that worried about patients who have degenerative low back pain, whatever the cause might be, but we are very worried when it's the first symptom of something much more sinister. And once that's been excluded, then actually from my perspective as a clinician, the pressure is off in a lot of ways. Yes, patients might still be very sore, but the pressure is off, because at least, pain is pain, but having a prostate cancer that's spread to the spine is much, much worse. Having a nasty infection in the spine is much, much worse. Or having some other condition which mimics low back pain, there's a few of them, is much, much worse than just having degenerative low back pain. So the pressure is off, and what it means is that we can do the appropriate investigations. Then it's about working out whether or not, especially if they come to see someone like me, and not every low back pain patient comes to see a surgeon, but those patients who come to see a surgeon, fundamentally, they're coming to see someone like me because they want to be told, they want to ask the question, do I need surgery for this? The answer is almost always no, and sometimes it is yes. I would say,
the last resort.
Well, not so much last resort, but there is probably a small group of patients where surgery probably does help, but it's a small group. It's not everybody, but it's more about and then once a surgeon has made the decision, okay, surgery or not surgery. Once it's not surgery, then it's about, okay, these are the things you need to try. You really need to up your game and take this seriously, because the other thing that will come out in the discussion is that we don't actually understand well what the true pain generator is in degenerative low back pain. We don't. We have some surrogates, but we actually don't. Which means that if we, as we're talking about, clinicians who've done years and years at university and postgraduate study, PhDs, masters, whatever, if we don't understand it, well, then it means that you as an individual has to develop some strategies to try and work through it. So that's really what we're hoping to bring to bear during the talks.
So if I'm there and anybody else is there as an audience, will we be able to throw some questions to the panelists and participate in that way?
Definitely. So the session, so it's 1:30 registration, 2:00 the formalities will begin. I think we're planning for at least a 45-minute Q&A session. So that will be questions from the floor, from whoever's, basically any attendee can ask a question. There'll be microphones there. They'll be able to ask questions of any of the panelists. There will also be basic access to an online app where attendees can ask questions through the app. Dean Kotsianis, who's emceeing the event, proud Western Suburb boy, and also a resident at the new Footscray Hospital. He will basically read out the questions and shoot them through to all of the specialists who are available. So there's definitely going to be scope for interaction on the day. It's not going to be a passive event where you've got full talking heads droning on for 2 hours.
And Dr. Dimou, the relationship with Pronya, you've collaborated with Pronya. Why Pronya?
Yes, I mean, Pronya plays a very prominent role in certainly in Victorian society as a Greek welfare and social justice organisation. One of its raison d'etre is certainly health education. I think this is a really excellent opportunity for any patient or anyone out there in the community who has low back pain, who has been struggling with managing their low back pain, has maybe misunderstood how they should be managing it or what they should be doing about it. It's a free event. There'll be some snacks and coffee provided. You'll get to see the new hospital, which is a very impressive facility. There's no question.
I'm excited about that, I can tell you now.
And so I think for people like that, it's an excellent opportunity to essentially get some free advice for 2.5 hours.
Thank you so much. Now, the final question when we let you go, and to say a huge thank you for having you live here at RPPFM, the KK Factor Greek Eurobeat show. If every listener today remembered just one thing about protecting their spine, what would you want it to be?
Oh, stay mobile and don't sit down for too long.
Fantastic. Dr. Dimou, thank you so much. It was a pleasure having you, and I look forward to the event. I look forward to seeing you live there and listening and learning, because, I've had my own journey but it's good to learn because learning also helps me understand. And when I understand, I cope better.
Absolutely.
Thank you so, so much.
I'm looking
Thank
forward to
you.
seeing you and hopefully some of your listeners there as well on the day.
Thank you so much.
Have a good night.
Have a good night. Enjoy the rest of the show. Thank you. Wow. What an amazing professional, Dr. James Dimou. May the 31st at 1 o'clock at the Footscray Hospital. Get onto HMSA, Hellenic Medical Society Australia, and get all the details. And I hope that you guys can get out there or pass on the message. You know, maybe there's friends of yours, family members that are, trying to cope with back pain, or they're caring for someone who has back